Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody is doing great. We are going to do the second lecture of today for the physical examination, which is going to be the abdominal pain. So, yeah, it's the one. All right. Okay. So let's start from here. Station frame, what the examiner expects you. Again, abdominal pain is one of commonly tested subject in narcoscopy. The reason they like it is uh, it is not something like neck pain that the patient could get hurt. Abdomen is a little bit, it is hard to hurt somebody in the abdomen. So they love to bring this as one of the physical examination. So please make sure that you understand everything in abdominal examination. The core objective is demonstrate a safe, organized, respectful, and hypothesis-driven abdominal physical examination. Candidate must show identity check, consent, and hygiene exposure and positioning and inspection before touching the abdomen, pains question before palpation, painful area examined last. So when we are checking for the joints, right? For the joints, we usually start in normal practice, we start with the healthy joint and then we go to the affected joint. But in exam, since we don't have time, we start with the affected joint, right? But here, when it comes to abdomen, you ask where does it hurt? When the patient shows that this area, for example, liver, you start away from that area. So that should be the last part that you need to check, okay? So systemic palpation, then percussion, then auscultation, relevant completion steps and concise synthesis to the examiner. Typical timing targets, 1 minute introduction, 1 to 5 minute exam, 5 to 7 minutes spatial science completion, and final 30 seconds summary. But you have to find a way to manage your own time. So high yield station flow, introduce yourself, confirm the patient, ID and date of birth, explain your position, your role, take consent, position the patient, expose appropriately, and inspect from the end of the bed for the general inspection, and then focus. Obviously, you have to be close to the patient. Always we start with the hand, then face, chest, then abdomen inspection. Ask about the pain, superficial, then deep palpation. We always do the palpation, the superficial palpation, then we do the deep palpation. But most of the time, before you do it, just verbalize it, because two things happens. One, if you do the deep palpation, first of all, the patient is not a real patient, so everything will be normal. Secondly, it is waste of time. So as long as you know that I did the superficial palpation, now I would like to go ahead and do the deep palpation, look at the examiner, and the examiner will tell you skip. Okay, so you don't waste your time, but you have to verbalize it. If you don't verbalize it, they think, or they keep, they think that you probably don't know that after superficial deep palpation, you need to do a deep palpation. So you will lose mark for it. I'm so sorry. I did get a call. I don't know if do you guys still have my screen? No? You do? Okay. All right. And liver, spleen, kidney, Murphy sign if relevant. But today, since we're doing general, we are doing everything, but specifically for a specific condition, we need to do the specific physical examination. Percuss, assess ascites if indicated, then auscultate. We should start actually by auscultation. We should start by auscultation. If we do the percussion or palpation, then this is going to cause extra vowel sound, which is not going to be, which is going to make it very hard for us to differentiate between the sound that we are looking for and the extra sound that is created by percussion and palpation. Thank the patient, cover, wash hands, summarize findings. Examiner, shorthand, safe plus smooth, systemic, synthesized approach. Suggested ASCII wording. Hello, my name is Dr. Ahmad Mahmoud Kalbi Maksud, whatever. I have been asked to perform an abdominal examination. This will involve me looking, feeling, tapping, and listening to your abdomen. I will keep you covered as much as possible and stop if you are uncomfortable at any point. Is that okay with you? Thank you very much, and move on and start your examination. Then do all the following before touching the patient. Confirm full name, date of birth, wash your hand, expose from the xephisternum to groin with a dignity, preserve, always keep the dignity or preserve the dignity. You need to cover the private area. Lie patient supine with one pillow, arms by side. Usually when the patient is lying down, ask the patient to keep their arms on the side and knees slightly flexed. Remember that when the patient is lying flat, if you perform the physical examination without asking the patient to flex their knee, you might not get the physical examination done properly. Okay, so you ask the patient to flex the knee. Ask if they have pain now and whether they are comfortable. Do not forget if pain is present, examine the area last. So it means we start away from the pain, and the pain area or the area that's painful should be the last thing. Setup checklist, consent, exposure, position, comfort. Common opening error, starting palpating before asking about the pain. This is a very common mistake, but we should be avoiding it. Poor exposure or patient left tense with arm over chest or head. Like when sometimes, remember that a standardized patient are acting, I'm not saying they're acting like regular people. It means they have never been there. They don't know what's going on. Sometimes they might intentionally cross their leg or put their hands behind their head like this. So it is our job to position them in a proper position before starting and performing physical examination. So can I have your hands by your side? Can you flex or bend your knees a little bit? Okay. No consent, no identity check, or no hand hygiene. These are the things that usually when we get to the station, we might forget about it, and they're commonly mistaken by MGs. Please do not make the same mistake. Inspection sequences from the end of the bed to the abdominal wall. General inspection, distress, pain, posture, jaundice, pallor, cachecte, hydration, bedside clues, bowel, drain, catheter, IV fluid, stomas, appliance. Observe whether the abdomen moves with the respiration. Hand face, hand clapping, leukonesia, nicotine staining, bruising, astraxia, eye and mouth, sclera icterus, conjunctival pallor, dehydration, and ulcer on jaundice. Chest, spider nevia or angioma, gynecomastia, scar, scratch marks. Why this matters? These clues frame hepatic, inflammatory, malignant, and systemic causes before local abdominal finding are sought. So these are the things that you need to verbalize it to the examiner, that this is these are the things that I am looking for a specific condition like this, right? For example, leukemia, I'm looking for hypoalbuminemia. Or clubbing, I'm checking for clubbing to rule out IBD or primary biliary cirrhosis or cholangitis. And for example, astraxia, hepatic encephalopathy, right? So abdominal inspection, contour, is it flat, distended, scaphoid, asymmetric, scar, hysteria, rash, bruising, visible vein, masses, hernia, stomas, visible pulsation, abdominal aortic, aneurysm, right? Or peristalsis, umbilicus, position, and scan change. OSCE phrase, I'm inspecting the abdomen for contour, distension, scars, mass, hernia, veins, and scan change. Use a consistent 9 region or 4 quadrant pattern so you do not miss any an area during the palpation and percussion. So it's always good to divide it into 4 rather than 9. It makes it easier, unless you have enough time. Palpation technique, safety, and organ examination. Before palpation, ask exactly where the pain is and where it is worse. Warm hands, wash the patient's face throughout. Why? Because when you touch the patient abdomen, sometimes they might not make a noise like ouch. They probably just make a facial expression like this. So when you're touching the patient, keep looking at the patient's facial expression or facial change. Sometimes we do not make any noise, but we change our facial expression. For example, if it is painful, something like that, right? Superficial palpation, assess tenderness, guarding, and superficial mass. Use gentle pressure across all region, okay? And I will show you how to do it when we actually start the physical examination. It's a little bit tricky. Deep palpation, assess deeper tenderness or masses. With a deep palpation, you ask the patient to take a deep breath in and then palpate. When you're going actually for the edge of the liver. If mass found, size, shape, surface, consistency, mobility, and tenderness. These are the things that you need to comment on. Targeted organs and signs. So liver. If you want to check for the liver, usually for the liver age, we start from the right inferior iliac fossa and we slowly make our way to the liver. And for the spleen, we start from the same side and we go not directly up, diagonally, diagonally. So we go diagonally. Okay, and the reason that we are not starting from the inferior iliac fossa is that when the spleen enlarges, it goes right side, not lower or down. So it goes right side. That's why we start from the right side. Kidney by manual palpation or ballot if the enlargement is suspected. Murphy's sign is right upper quadrant palpation under costal margin. Arrest of an inspiration suggests cholecystitis. Suggested phrasing during the right upper quadrant examination. I'm going to press gently here. Please tell me if this is painful. Now take a deep breath in for me. Okay. Examples, a calm, gentle technique, scoring better than fast, forceful palpation. Percussion and auscultation. Percussion priority. Percuss all quadrant for tympani versus dullness. Tympani is normal. Dullness is not. So estimate liver span if relevant. Percuss splenic area when splenomegaly is concerned. If distended, assess for the shifting dullness, fluid. Fluid trails only if marked ascites is suspected. So shifting dullness and all that, we do it if ascites is suspected. Otherwise, If you want to just see for the free fluids, you can always do the percussion while you're asking the patient to lean to one side. After 10 seconds break, then you check it again. You might feel a resonance or the tympany rather than dullness. Then in that case, it is just a free fluid. Auscultation priorities: listen for the bowel sound, consider Bruitt's if clinically relevant, aneurysm, vascular disease. OSCE note: some curricula teach auscultation before palpation, and OSCE marks usually depend on more on mentioning and performing it clearly than on the rigid sequence alone. So the proper way is to do the auscultation before doing the percussion. Okay. When aside is suspected, and inspect for the distension, bulging flank, everted umbilicus, percuss from the central tympani to lateral dullness. Repeat after turning patient to test for shifting dullness, but remember, there should be a pause of 10 seconds. Then you repeat, okay? Because it takes at least 10 seconds for the fluid to move to the move downward to the gravity. Interpret with the whole clinical picture. Do not overcall. Completion phrase: I would complete this assessment by checking vital signs and examining related system if indicated. How to present finding: example station with the right upper quadrant pain. Example positive finding: right upper quadrant pain, tenderness. Positive Murphy sign: mild abdominal distension, no general peritonism, no obvious abdominal mass, bowel sounds present. So this is how you present the finding, okay? Most likely interpretation: these findings are compatible with acute cholecystitis in the appropriate clinical context. Differential diagnosis: biliary colic, cholangitis, hepatitis, peptic ulcer disease, pancreatitis, right lower lobe pneumonia. Right lower lobe pneumonia. Next step, you may mention vital signs, analgesia, NPO if acutely unwell, CBC, electrolyte, bilirubin, LFT, lipase, CRP, abdominal ultrasound, strong summary statement. This is a focused abdominal examination of a patient with abdominal pain. The key findings are right upper quadrant tenderness and a positive Murphy sign without evidence of generalized peritonism. Overall, these findings suggest acute cholecystitis. This is the proper way of summarizing your finding. So my patient has right upper quadrant pain and Murphy sign is positive, and that means that the patient other sign and symptom that points toward the peritonitis is negative. So most likely my patient has acute cholecystitis. Why this scores well? Names finding before diagnose, avoiding over-claiming, sound clinical, concise, and examiner friendly. This is what they expect you to say. Now, professionalism, examiner checklist, what earns more quickly? So what are they expect you to have? Professionalism, like what do we expect us to perform in this station? Very important slide. To introduce ourselves, to confirm the patient ID, to obtain consent, to have a proper hand hygiene, maintains dignity of the patient. Now, in an inspection, what do they expect us to do? The first one, the general inspection, is supposed to be done from the end of the bed. Hand, face, chest, abdominal contour. We should verbalize it. Mildly distended, whatever, right? Scar, veins, stomas, visible mass, hernias. Now for the palpation, what do they expect us? Ask about the pain first before palpating. Superficial, deep, superficial, then deep. Again, they might ask you 99% of the time, they may tell you to skip, but mention it. Painful area last, which again, before we start, we asked for the location. Liver, spleen, kidneys, we have to check for them. We have to make sure there is no organomegaly and there is no issue with the kidney, at least in terms of structure and size. A spatial signs of relevance, if relevant, and for the percussion, quadrant percussion, it means we have to cover every single quadrant. Ascites if indicated, bowel sounds, and bruits if relevant. How do you do that? How do you auscultate and percuss? For the usually for the abdominal aortic aneurysm, we do the auscultation. And that's the beauty of doing auscultation first. If the bruits is positive, we usually take it easy on palpation and percussion because the chances of bursting the aneurysm is high, right? If the bruits are ahead. And thank the patient, cover the patient, wash the hand, mention completion of steps, and summarize. So these are the things that helps us secure good mark. If you follow these steps and structure in the station, should be good. Professionalism, inspection, palpation, percussion, and closure. Then common errors, touch the abdomen before asking about the pain. It means palpating before asking the pain. Where does it hurt? Lever. And you start right away from the lever. And as soon as you touch the patient, say, ouch. And that's it. Exam is done. You have to stop right there. Okay? So before we touch, we ask the patient, where does it hurt? Lever. So I'm going to start all the way from the inferior, left inferior iliac fossa. Then I'm going to make my way to the lever side. Palpate the tender area first, which is again going to be end of the station. Ignore patient comfort or expose poorly. You don't expose the abdomen. Poor exposure, poor inspection, poor physical examination. Raise true organ with an unclear technique. Unclear technique, no, it's racing. Don't race, be focused, be professional. So I know time management is very important, but how we should change our performance while we are keeping track of the time at the same time, how do we do that? So if we race, they know that we know how to do it, but actually it costs a lot of mark. So do not race, try to cover everything and appreciate everything you do. Thank the patient, be nice, and be very gentle with the patient. Only the race part to you. Only the race part, not the other parts. Does not inspect systematically, ends without summary or next step. Remember, an OSCE is not just a physical exam, it is a demonstration of safe clinical behavior under supervision or observation. So how do we perform safely? Okay. Better replacement. Before palpation, do you have a pain anywhere? I will examine that area last. During palpation, please tell me if this is painful. I will be gentle. So these are the things, if we say, it's not like they have these specific sentence that they mark you. No, they have a specific communication columns that when you say these sentences, they tick mark those communication columns. Oh, this is covered. Very professional, very nice, very kind, right? When it is short, state clearly what you would complete rather than silently skipping it. At the end, name the name finding first, then likely diagnose. What are the things that I found? And based on those findings, this is the diagnosis. I don't say the diagnosis first, then the finding. These are my findings. Based on my finding, this is my most likely diagnosis. Okay. And the full sequences, wash hand. I don't want to go through all of them because you know it by now. So practice target before the cessation out loud until your translation sounds effortless and patient-centered. So you have to keep practicing it. So I think this is just the summary of the whole lecture. Thank you very much.